Good morning, everybody. It should really be called the Meet the Expert session, which is Tracey. So I brought along somebody who actually knows what they're talking about. So Tracey is a little bit blind. So if you could move as close to the front as possible, that would be really good. And I will pick on the furthest person back, just so you know. Okay. So who has a CPE policy? Who doesn't have a CPE policy? Okay, good. Well, I hope that this session will highlight some of the key issues that we went through when we were building our CPE policy and approach generally, which was forced by an outbreak that I'll talk about. So this is just a little bit of background and context across Europe. And I think the most alarming point from this slide is the increase in carbapenem-resistant Klebsiella, which has gone from less than 2% in 2005 to almost 6% in 2014. Now, we don't see those kinds of figures in the UK. This is mainly driven by very high rates in Southern Europe. But obviously, with lots of transfer of patients and staff across Europe, this causes quite a lot of importation of these cases. In the UK, the picture shows a stepwise increase in the number of CPEs sent to the reference lab. I've got some data that one of my team will present later that suggests this is at least a tenfold underestimate of the actual number of cases out there. So we should be adding another 0, if not more, to the scale of this problem. This is our CPE picture locally, and it's quite an interesting picture. There was a very significant event that happened in April 2015, which was me starting. This was the situation before I joined, and this was literally my first month in the job. Now, I don't think it had much to do with me, honestly, but what we started doing was extending our screening program much more broadly. And you can see the significant blue chunk there. That was a single clonal outbreak of an NDM Klebsiella, which we've had 40 cases of to date. Fortunately, none since October last year. And you can see since we recognized it and started putting in some interventions, the number of cases has dropped nicely. But what was really interesting is the other clustered cases in the different colors have all been picked up by screening. And I'm sure they were there before. It's just we weren't picking them up. So we've caused ourselves an interesting problem by all this screening. And we are now, I think, the second most common CPE producing trust in the country, behind Manchester. And I don't think it's because we have particularly more cases. I think it's just we're doing lots of screening. So we have lots of guidance to help us putting together a CPE toolkit. I think actually the CPE situation has prompted a patient safety alert, a toolkit, and a letter to all CEOs. I don't think any other bug has done that in the past. It's the first time that those three things have come together. And I'm really pleased that the government and authorities are taking this so seriously, because it is a potentially big threat. And there's some guidance in the US as well, which is useful for comparison. So on the next slide, I have collated all of the evidence from intervention studies that show which individual interventions work to prevent the transmission of CPE. There isn't even a single study with a single intervention to show whether or not it works to prevent the transmission of CPE. So we've got a dearth of evidence, which makes it really difficult to put together evidence recommendations or even an evidence-based policy. And the only other preamble I want to make before we get to the interventions themselves is that guidelines is not the same as policy. We've been asked countless times by our management in the organization, well, why don't you just implement the toolkit? You can't do that. It's a piece of guidance. It's not specific enough to be policy. So you have to make some difficult decisions in translating the guidelines into a policy. And we're going to touch on a few of those today. How many hours do you think we've spent discussing this, Tracey, CPE, over the last 18 months?
A lot.
More than half an hour. So this is only going to touch on some of the key issues that have come up. So this slide is split into two. The black blobs are meant to represent the interventions that all of us would agree we should do some of the time. The grey are the more contentious issues that some would argue we don't need to do at all. And we're going to pick out a few of these to talk about in more detail. And finally, before we get to the questions, these are some resources that we're happy to share with you. If you see anything interesting, drop us a line and we're happy to share it. Okay, so if you have got the conference app on your phone, then you'll be able to see the questions that we've posed for voting. So if we can switch to the voting screen. Thank you. So the idea is that we do the vote, and then we'll talk for a moment about the key issues that have come from it. So the first question that you should be able to see, and you might have voted on already, is who should be screened for carriage on admission? So can we go to the results? Okay, so nobody says nobody, which is good. 10% of you think all admissions to high-risk specialties only. 10% of you think risk factor-based screening of all admissions. 72% of you think admission screening to all admissions to high risk plus risk factor-based admissions. And 8% of you think everybody. Oh, somebody else has voted. Keep voting. So actually the toolkit recommendation is the third one down there, to do risk factor-based screening of all admissions. It doesn't mention anything about universal screening in high-risk specialties. So, does anyone feel brave enough to explain why they chose the fourth option there? Have we got a roving mic, just so we can hear? Down at the front here.
Cost. I don't think that the trust would, on other organisms that we've followed, would just do blanket screening.
Okay. Comment at the front here. 2 comments.
Thank you. I chose the fourth one, partly because of cost, but also when you look at risk factor-based screening, it's quite open to interpretation if you look at the PHE risk factors. And indeed, in our experience, we found, what does receiving healthcare abroad actually entail? Is it administering your own TPN, or is it receiving antibiotics? How do you limit that? So actually you do screen quite a few people within that.
Yeah.
I just wonder as well if somebody thinks that we should screen everybody and cost isn't an option, if cost wasn't an option, would some people have voted to screen everybody?
No.
Because we couldn't isolate them anyway, so...
Yeah. Yeah. Okay.
The fear culture.
Okay. All right, thank you.
Okay, interesting. So we do the fourth option. We do all admissions to high-risk units, which includes the ICUs, all renal and vascular and haematology wards, and somewhere else that I can't remember.
Bone marrow?
BMT, yeah. And then risk factor-based screening of everybody else. So we're screening about 40% of our admissions to the trust. And our risk factors are anybody who's had previous hospitalisation anywhere in the last year, including our own readmissions, plus overseas residents, because we feel that that's probably likely to be as big a risk factor as overseas hospitalisation. Okay, can we go to the next question, please? Okay, so how many screens should be used, and should preemptive isolation be applied? Can we see the results? Okay, so a bit of an even split here. So 20% a single screen with no preemptive isolation, 25% a single screen with preemptive isolation, 6% 3 screens separated by 48 hours with no preemptive isolation, and the majority, or the most common answer, is 3 screens separated by 48 hours with preemptive isolation whilst awaiting for the results. I'm pretty surprised, actually, that that's the result. I did a straw poll of trusts in London to talk about what they were doing, and I couldn't find anybody else who was actually following the PHE recommendation to do 3 screens each separated by 48 hours in London.
We've just started implementing it, so that's what we're actually going with.
Okay.
So we have 3 screens, 48, well, it takes the 96 hours to 0. We do the screens at 0, 48 hours, 96 hours, so in theory it's taking like 4 days to get somebody negative. And we are preemptive isolating them, but you take into consideration where we live in the southwest of Scotland, we've had 5 like CPEs for 2007.
Okay.
Probably get that in a week. So
Yeah.
that's
Yeah.
kind of why we're going with that.
It is interesting as well, because before we had our outbreak situation, that's what we were doing. We were doing with no preemptive isolation, purely because we just didn't have the capacity to do that. So no, I'm really surprised at that result as well. It'd be interesting if we could ask it now to ourselves, what we would be doing.
Yeah. So to take a step back, the 3 screens thing, so the PHE toolkit recommends doing 3 screens separated by 48 hours.
Yeah.
Because I think there's a concern that that there'll be an unmasking effect of carriage that's not detected at the first screen, but various hospital exposures or antibiotics unmask carriage that's there but wasn't detected on the first screen. Now, as far as I know, that's not an evidence-based recommendation from PHE. It was conservative, based on some related data, but not specific data related to CPE. Okay, we have a comment.
That's what we do in Belfast as well, just what the guys just said in terms
Okay.
of the and we do preemptive isolation.
Okay.
And the problem is capacity. The problem is environmental issues in terms of finding enough places to isolate people. So it's not just the screening, it's about how you manage that afterwards. For us, that's the challenge.
Yeah.
And potentially our numbers are very small. Well, at the moment they're very small. Potentially that could get bigger, obviously. But we do the 48-hour, 96-hour screening. Yeah.
A comment towards the front here, while the mic's going. So we as Tracey said, we started off doing 48-hour screening. When we looked at our data, we actually weren't. Operationally, we failed to implement it. So when we looked at all of our screens and the time points that they were taken, you should see 3 peaks in terms of the screens, and we didn't. We just saw a first peak and then a flat line. So operationally, we failed. So any tips on how that's implementable, I'd be grateful for. So the other thing we did is we went to the data, and the small number of patients that were screened on that time frame, we found no difference in the carriage rate of CPE on the first versus the second or third. And there's a presentation later on this morning about that data. And we've used that data set to justify moving from 3 screens to 1 screen. And operationally, it's been a big bonus. Okay, comment towards the front here.
I work in NHS Lothian and based in Edinburgh, so we've probably been doing screening for probably about the last 3 years or so. We actually do it on a bit of a risk-based assessment as well. We do the screening in 48 hours, but we actually risk assess the patient in terms of where they've been hospitalised abroad. So if it is a high-risk country, then we would then isolate them. If it wasn't in a high-risk country, then we would not isolate them, but screen them, but follow standard precautions until we could get the screens back, so because of the problems with isolation and things.
Okay, so risk factor-based preemptive isolation. Okay, that's probably more workable for us than universal preemptive isolation, if that makes sense.
Thank you. Yes, John, I was thinking something similar. Is that if you've got speciality-based screening, how can you do preemptive isolation in that sort of setting?
Yeah, I mean, if
Does that
you're
make sense?
if you're universal screening in a specialty,
In a specialty,
you
you're talking about
can't-
high-risk specialities such as ITU.
Yeah.
You're obviously not going to preemptively isolate all those new
Yeah.
admissions.
Because the specialty is the risk, so
Yes.
everybody would be screened, yeah.
Yeah.
Could I just go back to the lady who was talking about your experience? And one of the challenges we've had is actually asking those questions on admission, and especially we've recently switched to an electronic record system. Did you have any experience of asking those questions? Have you had healthcare abroad in the last year? Probably at the A&E stage or the sort of admission unit stage. Oh, sorry. So your question and then you can't talk back.
We actually try to identify the patients, everybody who comes into hospital, there's a risk assessment in their notes which says, have you had dialysis in a hospital outside of Scotland or within, outside of Scotland is the kind of key that we say. Have you been an inpatient in a hospital abroad or a hospital outside Scotland in the last 12 months? And anybody who's had admission to a high-risk area such as burns, plastics, ITU type setting. And we also have anybody who comes in with a foreign postcode or an address or an unknown GP. That is also flagged up to us as well, and we then follow that up as well. So we try to get people kind of from two angles, and there will be people who fall through the net, but that's kind of the way that we've found is the easiest way to try and get a hold of people that are maybe at risk.
Okay, thank you.
Okay, one more quick comment and then we need to move on.
Can I just ask, have you had any difficulties with getting samples? Because we seem to have, our critical care colleagues in particular seem to be anti-rectal swabbing. And obviously, in terms of waiting for a patient to produce a sample, if you're on a 3-screen I'm just wondering whether that's prolonged your time to, or would have prolonged time to results for a lot of other people.
Yeah, so we've had to do quite a bit of staff and patient education around the need for a rectal screen or a stool specimen. In microbiologically, a stool specimen is preferable because you've got a bigger load in there, obviously. But rectal screen is more convenient in terms of timely specimen. We had a situation where one of our ICUs was wedded to a perineal sample rather than a rectal sample. So we've had to overcome that barrier and educate them to explain that actually a perineal sample is around half as likely to pick up a true carrier. So they just need to get on and do a rectal sample.
I was actually quite surprised that the nursing staff weren't as resistant. We did a lot of engagement with them. We produced sort of how to take a rectal swab as well, and we also produced a leaflet for our renal dialysis patients on how in a renal dialysis setting it's obviously very difficult to get privacy and dignity, and so we have some information now on how a patient can take their own rectal swab as well, and I think information is key.
Yeah, I've found in my experience it was the nursing staff that were very resistant, and they all thought the patients were going to refuse, and in practice, as soon as the verbal information being given, they've had no problems with, I think, only one patient out of the hundreds that was probably screened in the last few weeks. Not hundreds, but tens.
Yeah, it's a really important point. So I think the message to the patient is crucial. I was involved in a study in another London hospital where we had a really high decline rate initially, sort of 50, 60%, because the script for the staff was to start talking about carbapenemase producing Enterobacteriaceae. And the patient had switched off before he got to the end of carbapenemase. And when we started talking about antibiotic-resistant bacteria, a bit like MRSA, our compliance went through the roof. So we need to make sure the message to the patient is clear. And also to make it clear that it was good for the patient and for their peers to know their carriage status.
John, it is final point for me is it's very postcode orientated because like in the southwest of Scotland, as I said, we don't screen that much. We do the risk assessment and all these kind of things, but a lot of our patients don't go away from Scotland because we just love the weather there. So I don't really. I think it definitely comes down to postcode. You've got a high incidence in London, Manchester, things like that. We don't really get it in Kilmarnock and Ayr and sunny Troon and so on.
Okay, we need to move on because we've got 10 minutes. The programme's a bit weird. It looks like we're going to carry on for after 9 o'clock. It's only because Tracy's name's too long, so we're not. We're going to finish at 9, so don't worry. Right, can we have the next question, please? So PPE required for managing a carrier should be nothing. Nothing. Who said nothing? Okay. Gloves and plastic aprons, about a third. Gloves and gowns, about half. Gloves, masks, gowns. Gloves masks and gowns or aprons 10%. I'm fascinated. Right. I will let you speak about gowns, Tracey.
This is my hobby horse. I am intrigued to, if anybody wants to sort of put their hand up over the parapet about the preference of gowns over plastic aprons.
It's just because we had a recent experience related to it, and it was from urinary tract. So we only used gowns for physio who were having direct physical contact with the patient during mobilisation practice kind of thing. Rest of the time it was gloves and aprons. So we kind of utilised HPS Toolkit, which recommends that you would only wear a gown if you were actually physically going to touch the patient and there was an area that was not going to be protected by gloves or an apron, i.e. close contact that could to your shoulders and things like that. So that's the only time we went and recommended a full length gown when they would wear it.
And would you risk assess to have just a plastic apron if you were just going to have minimal physical contact with the patient?
That would be routine, because what we
it would
did
be
is,
two-stage?
again, because ours was so, as I said, we've only had 5 for 2007. So when we get a case like that, what we do is we kind of intervene at the time and spend time with the clinical staff at the cold face, so to speak.
Yeah.
And we tell them exactly, here's what it is, here's what you have to do, and here's definitely what you don't do.
Yeah, okay. Thank you. Anybody else's experience on gowns which is different to that one?
It's funny, I was speaking to Eli yesterday from the States, and he was like, what's an apron? So they don't have this issue, they only have gowns.
Right, okay.
So they don't have an apron option.
When we first encountered CPE in our hospital, it was on an elderly care ward where a lot of the patients had dementia and had quite high nursing needs. So it was felt that because they were holding on to staff, I know there's not evidence in favour of gowns, but the staff, well, felt more comfortable with it because of the close nursing contact they were having with these patients. But we do risk assess depending on the patients. If they're high risk, if they have dementia or like a physiotherapist, then we would do that.
Yeah. Okay, thank you.
Would anyone like to comment why they included a mask in the PPE kit for managing a known carrier?
Like we have recently patient with CPE positive in the sputum with trachea. So when he was coughing, like expelled a lot of sputum, we asked to wear the surgical mask with the eye shields because it was very often the splash risk. And even when the one nurse she didn't wear the mask, she has the sputum on her face. So
Ugh.
yeah.
That's
But I have a
gross.
question about the gun. What about because it's discussion, it's not many in the publication about the children. What about the parents who spend all the time, with the children? It's impossible to wear the plastic gun.
Yeah, I mean, I'm not actually sure what our recommendation is on that.
It's not specific to CPE, it's more general, especially I think we mentioned it in our MRSA policy, that if the parent is acting as a caregiver, so if they're having the sort of same interventions that a nurse or another healthcare professional would have, then we would expect them to apply the same principles of PPE, risk assess what you're going to do, and then decide what you're wearing. But to just be in a room sitting with a child and not touching them, we would just advocate hand hygiene and the usual principles of infection control rather than sitting there in a full gown and mask and visor or anything like that. So it's about educating the parents as well and knowing the difference between a family member who's just sitting there versus someone who's acting as a caregiver. I don't know if that's very different to what anybody else does. Ooh, right at the back.
A paediatric infection control nurse would like to comment.
But adult trained, done general as well. Interesting your comment on that. I would find it very difficult to implement telling parents to wear PPE, even as caregivers, thinking about long-term children with track events and things. Those parents are highly trained around hand hygiene. We really focus on hand hygiene, but making them wear PPE when it's having such close, and they are carers and suctioning, I think would be quite challenging, and you want to have a good relationship with that family and parents. So we kind of make the assumption if the child is colonised, parents are likely to be transiently colonised, but they're in the room with a child, so we kind of advise them about not using the parental kitchens and things. But thankfully, it's a rarity at the moment. And in MRSA cases, we put the parents on octinazine washes and don't bother screening. We just assume that there'll be some transient colonisation there. So I think with parents and direct carers of children, it's quite challenging and quite emotional as well. So I think we've always got to remember this is their family member and they're going home to look after this person too.
Okay, we don't have time, but I'm intrigued. Who said none? Does anyone want to justify no PPE?
John, sorry, I didn't ever say none. Never say none.
Okay.
But it's just this question which comes up with us quite a lot. Thank you. It's this question that comes up with us quite a lot, that you start putting gloves on people, and I think you alluded to this, is that hand hygiene actually can go down as far as compliance goes. So are you always making things safer by always saying gloves? Because people misuse them.
Just ban them. Ban gloves. Take them out. Okay, next question, please. We've got 4 minutes left, and I've gone red, and we still have 2 questions. Okay, so what should be used for terminal disinfection following a case of CPE? Okay, so nobody said nothing special. The majority said bleach, sodium hypochlorite, a third hydrogen peroxide vapor, 5% UV, and 21% depends on the context. So the toolkit recommends nothing special, the first answer that nobody selected, which I think needs to change, frankly. I think we do need to enhance our cleaning and disinfection when it comes to terminal disinfection following a case of CPE. For us, it depends on the context. So in most cases, we use sodium hypochlorite. During active outbreaks, we use hydrogen peroxide vapor. I think there could be a role for UV in the management of healthcare-associated infection, but probably not following a case of CPE. Anyone got a quick comment? Yes.
We actually have a local strain of CPE, and then we've had one NDM and one Oxa imported into the trust, and for those we have actually used the HPEV vapor, but we've decided for our local strain to just stick with the hypochlorite.
Okay, similar to us. Okay, lots to say about that because it was a journey, really, wasn't it?
Yes, and I just wonder as well, is the answer to that guided by what you currently have or what you would have in a blue sky situation?
Yeah.
Because I wonder how we would answer that.
Yeah.
But
yeah,
we should aim for what we want rather than what we have.
I mean, we started off doing nothing special with soap and water for terminal cleaning for CPE. We've kind of gone up the scale as we feel that the risk has increased. Okay, last question, 2 minutes. We'll finish on time. Staff should be screened for CPE. Okay, 41% and a little bit more never. Less than 10% during outbreaks, about 40% during ongoing outbreaks, and 4% routinely. Okay, I mean, the big issue is what on earth do you do with a carrier, a staff carrier? You can't decolonize. You might be able to use some chlorhexidine to reduce the skin burden. We hope that our staff have good personal hygiene and wash their hands regularly. Sometimes they don't. Tracey, what do you think about this?
I think it came up in one of the talks yesterday as well about, if you do employ your hand hygiene, I know that sounds, what we're promoting every single day, but again, it's about knowing the organism that you're finding in the staff, that it's the same as if you're during an outbreak, that you're finding that's, and are you blaming that member of staff? Is it chicken and egg situation? So I would vote for not screening staff, but obviously this is saying something different.
Never. What about during an ongoing outbreak?
I think I'd never say never, but I would be very reluctant to do it.
Okay.
I would be pushed into a corner to do it.
Okay. One more comment, then we really need to finish.
I would totally agree with that about the screening of staff, because we don't technically know what to do with a patient. If we get a patient that's positive, the way we perceive it is that patient technically will never be deemed as being negative, regardless of what a swab tells you. So for the NHS as us having we need to be open and honest. Can you imagine if we had staff members who we knowingly were carrying CPEs and a patient subsequently got that same strain and died, I think you're better off not screening at all, and it would be like in majorly exceptional circumstances when you would go down that route.
Do you know, there's a million things I want to say to that, but we have to stop. So thank you very much for the input. Thank you, Tracey. Thank you, Martin.
Thanks, everyone.